I'm sort of still continuing on this, kind of what I think is the most important in lateral surgery. And really, if you go down, no matter whether it's an ACR, a vertebrectomy, thoracic, it's really all about getting a good AP x-ray and a good lateral x-ray. And you have to really pay attention to that and spend extra time doing that. Jens?
I have a question. I have a question that pertains to comparison of XLIF and OLIF, and that is retractor duration. So when we do our traditional ALIFs, we have a vascular surgeon who is amazing, and he uses handheld retractors only, so no K-wires or static vascular retractors. Everything is only retracted as much as necessary, just for a short duration, and flow is reestablished by a retractor release. For the XLIFs, I'm sorry for the lengthiness of my question, retractor duration may also play a role with neuropraxia or worse due to the distraction and compression of the roots there. So please talk a little bit about retractor duration, A for XLIF and B for OLIF with different tangents, neurologic and vascular compromise.
So that's an excellent question. So for me, if you're going lateral, the key levels are L3-4 and L4-5. And again, depending on what system you use and what neuromonitoring technology you implement, I really like to map out the plexus. I want to know, like if I'm doing a lateral procedure, I want to be able to know exactly where it is. So if you're doing L4-5 and it's like you're not getting any, those are the worst injuries I've had when you think everything's perfect. There's always, if you're doing 4-5 or 3-4, I think retraction time is a huge issue. I try to, each level, I try to keep it under 15 minutes. As far as vascular retraction, that's a great question. I think when you're doing the oblique approach, because of the fact that it's such a small opening, I don't think you retract on it as much as we do with our colleague when we're doing open. I think it's certainly, I've done, and I think it's, for me, again, the vascular, I know when we do open, you don't want to retract on an iliac vein for as long, 30, 40 minutes. And so our colleague likes to kind of go back and forth. I just haven't really experienced that in oblique approaches, but I have to, I haven't done as many obliques as I've done lateral, but I think definitely for neuropraxia, it's a problem.
So 15 minutes.
I try. And again, I think one of the other things I've learned is through our, just our anatomical dissections, there's little branches that are between the femoral nerve, the nerve roots. All those are important, and I think some of the nerve injuries you get from doing lateral is actually not necessarily injuring the femoral nerve, but it's also injuring those kind of interconnections that I'll show you. Yeah, it's definitely, as we learn more and more about lateral, I think retraction time is a huge issue, especially for, I think, more so for nerve than venous structures. So this is a great CT of a normal spine, and you can see here, this is actually what the lumbar plexus really looks like in real life. The depiction, and I think we saw a couple earlier with Dr. Hines and Dr. Uribe, they're these old, and in our neurosurgery training, you're taught, you memorize like the brachial plexus, and they go, this is the core, these are the trunks, and you memorize it and then you forget. And it's like a cartoon character, it's in all the Grey's Anatomy, and you go to, they all copy each other. But when you go to, when you look at it in real life, you're like, God, it doesn't really look like that at all. I think the lumbar plexus is the same way. If you look at all the textbooks, they're all wrong, because this is what it looks like. And I remember when we first started doing these, and we would, cut everything. The internal oblique, the external oblique, we just bovie right through it, and we would have a huge opening. And then I would put my finger in and, dissect like crazy because I didn't want to hit the bowel. Well, guess what you're doing? You're disrupting all those nerves, the general femoral nerve, the obturator. I mean, all those, these are all intercostal nerves. This is actually what it looks like in real life. This is just work that we did in the lab, and you can see just even on an AP view, like if you're doing an OLIF or a lateral procedure, oblique approach, these are all nerves that, when you're in there, you can bugger up. And so every single nerve can be damaged, and we've had every single complication you can think of doing these approaches. And I was recently in Los Angeles, and this reminds me of like down, in LA, where Santa Monica, 405, you've got all these intersections, and this is a lateral view with K-wires going through, and basically what we did is in the lab, all the different nerves. So this is the lumbar plexus. So imagine, so you're doing lateral approach, and unlike any other procedure, it's not like you could move these nerves. They're fixed. And I'm going to show you in some of the slides that I have, they're not going to move. And I think that's why retraction, a lot of times you get those nerves are fixated in muscle, or they're pressed against a transverse process, so they get neuropraxia. I mean, all my patients, I tell them when I'm doing lateral procedures that they're going to wake up with their thighs going to be numb, and they're going to have some pain and some weakness because you're going through the psoas. I mean, you're going to get it. And I've done a lot, and I can tell you 100% of my patients get it. And if you tell them they're going to have this clinical symptom, somehow it's easier for them to swallow, and they go, okay, yeah, I'm going to have weakness in my adductors, I'm going to have weakness in my hip flexion, my hamstrings. Then it's much easier for them to deal with. And I just wanted to show you some cases and some examples. So, again, in my practice, what I found is doing revision surgeries is much more difficult going back in posteriorly. Like, you see someone, they've had 3 or 4 lammies, they have instability, there's something going on, and it's much easier to go lateral or to do, and what I consider lateral is either oblique or true lateral. It's much, for me in my hands, it's much easier to do that than to go back in. And this is an example of a patient that was 75 years old. And again, I had seen him a couple times, and this is his MRI and CT scan. He had surgery in India previously. He'd had like 6 or 7 surgeries. He had last time he had like an infection, epidural abscess. So you can imagine if you go in, it's like the 7th surgery, trying to, go back in and stabilize this. You can do it, but it's a nightmare. Very thin guy, not much muscle. And again, the importance of, being a neurosurgeon, we kind of poo-poo plain x-rays a lot. We don't look at the hips. We don't look at the entire spine. And fortunately, I'm in a practice where I have orthopedic surgeons, and, they x-ray like everything, even, like they try to get full-length standing x-rays, flexion, extension. And I remember when I first saw him, I just kind of, it was like one of these urgent referrals. You see him, and you don't really get plain x-rays, but this is what his plain x-rays look like. And you can see just from even just this view, you think, well, gosh, there must be some instability there. And you can see how different, just look at the difference between, being upright and, I mean, rarely do you see that much movement. But this is a case where, you can really see a difference between the upright x-rays and flexion extension and versus the CT and the MRI. And again, you can do this however you feel comfortable. I think you can do an ALIF, you can do a lateral approach, lateral being either approach this obliquely or you can go posterior. Again, I don't think there's a wrong or right answer. And unfortunately, this is one of the cases where I actually had a femoral nerve injury. And I'll tell you why I had it. I think in this case, the anesthesiologist had given him a neuromuscular blocker, and I didn't even realize it until later. And I was like, okay, everything's fine, everything's green, you know, not getting any issues. And then you can see, and this is how much instability the guy had on flexion extension x-rays. And I don't know what it is. I was talking to Dr. Murad from Colorado, but it's always the patients I've had the worst complications doing lateral surgeries are they're thin, they're older, they have no retroperitoneal fat. All my nerve injuries, vascular, bowel, you name it, have all been in patients who are extremely thin. And there's something about, maybe you have more retroperitoneal fat, the nerves are somehow more protected, your abdominal cavity, your peritoneum is kind of pushed more forward. And again, I staged him. I did a lateral first, and then I did a posterior. And the other thing that's interesting about this, I'm going to show you, is that so during the case, everything went perfect, and the guy woke up with severe left leg weakness. And again, where's the weakness? It's not distal; it's all proximal function. When you examine them on rounds, you're like, oh, wiggle your toes. Yeah, everything works great, right? Those are the wrong muscle groups to test. So I think at this point, he again was, had difficulty, had to use a walker to get around. But the other thing that's interesting is I followed this guy for 3 years, and got EMGs and everything, and it almost behaves, being a neurosurgeon, and this is early on when I started, this was like in 2007, is that, we really didn't understand a lot of these nerve injuries and things we were getting. It behaves very similar to like a peripheral nerve injury. And so people have, they get neuropathic pain, they get severe weakness, and then they get some function back, but they get severe loss of muscle mass. I mean, you can, take their shorts and their pants off, and you can see that, their muscles have been denervated. It's pretty devastating. And again, on this case, I followed this guy for 3 years, and this is his 3-year post-op CT scan. He had I could not see one single cell of bone going across the peak cage that I put in. And I think at the time in this guy, I think I put allograft. But, and there wasn't much of a fusion in the back, but I think because the cages are so wide, and again, there must have been some fibrous tissue that formed there or something. But, just because of how large the implants are, they don't seem to subside or, they don't dislodge. It's not like when you get a pseudo, if you do a T-lift where you get, the cage starts to, and you get gas and all these things. So, and again, it's interesting, back then, all the companies are selling PEEK. Oh, it's the greatest. It's indestructible. And then, it's 5 times the cost of, metal implants. And then now everybody's reversed. They say, oh, PEEK is, doesn't grow bone. It's bad. Don't use it. So we're going back. Now 3D printed is the cool thing. It, mirrors normal bone. It tracks osteoblasts, osteoclasts. And again, here's another case. I'm just showing some kind of more difficult cases, but cases, I kind of see in my practice where this is a patient in her 80s. She had a really, really bad radiculopathy. And being a neurosurgeon, I always kind of poo-pooed my partners would talk about, indirect decompression. I was like, oh, there's no way, you can't indirectly decompress a nerve. You have to go in there and find it and dig it out. And when you do these procedures, you can indirectly decompress a nerve, and I'll show you. But you can see, even intraoperatively, I couldn't see anything on this lady, like nothing on an AP, nothing on a lateral. And so what I did on this case is actually, there's slides that you can use, and there's different, I basically try to find the disc space. And you can see, again, this is what she looked like. She had adolescent idiopathic scoliosis, and surgery was done when she was like 12. She's put in a body cast. She did everything, and she had a horrible L4 radiculopathy. And again, she's in her 80s. She's got terrible bone. You name it. And the thing that was bothering her was the radicular symptoms. And she'd had previous laminectomies as well. Jens.
Do you mind talking about right versus left? This is a right-sided exposure, and osteophytes, concavity, convexity, safety of exposure, as you're discussing this case.
That's a great question. So, I like to go from the left. And there's several reasons for it. One is, I think, as far as vasculature, I think I'd rather, deal with, let's say, a arterial injury rather than a venous injury from the right. I do look at the MRI and the CT scan to look at the vessels, so that makes a difference. I used to always go on the concavity, but now I just go from the left, because one of the things I found out is that when I would, when you book the cases, sometimes you'd put right, and then the OR would get all screwed up, and then they wouldn't necessarily, and then, when you get a routine going, you just kind of stick to it. So I finally said, look, I just do everything from the left side up. It got too complicated. So in this case, the reason why I didn't go from the left side, and again, it's not always, but like 90% of the time, you can see if I went from the left side, it would be an impossible angle. You'd have to basically go through her chest cavity to get into that disc space. And again, I've done, you get these people all lined up and you abort the case because you can't see anything. So I've done that as well. We've literally had every single, and the other thing actually that Dr. Chapman was trying to point out is the large colon tends to be more of a problem on the right side than the left. And unfortunately, I've had bowel injury as well, and there's just something about going in from the right. I just much rather going in from the left. Again, these are what I did on her is I found the disc space visually because I couldn't really see it under fluoro. And then a lot of these companies have these malleable aluminum type, basically you put it in the disc space and then it kind of gets you in. And then I slowly start to dilate that area up. But you can see in this case, I'm using angled instruments to get in. And then I put in the thing about doing something like this is you don't want to get into the end plates. And so I put these malleable instruments in to keep the cage from just going into the end plates. But having said that, it's really easy to get into the end plates on a case like this. So, and again, I don't know if you remember, but look how much indirect decompression we got just from, you can see here on the sagittal view, you can see how bad the foramen is there. And you can see, and again, you're not going to get, this is an 80-year-old, you're not going to do an ACR. My goal here was to basically do an indirect decompression of that nerve. And then I went in posteriorly, I think we went L2 to the pelvis. And you can see, she's just got a terrible deformity, but my goal here was just to kind of indirectly decompress the nerve. And again, you can see we sort of, you don't necessarily want to, but you can see and I think at the bottom level, we got a little bit of the ALL kind of, in these older patients, you can get the ALL to kind of rupture. And then again, as you feel more comfortable doing this, I've gone in laterally and taken out T-lift cages. I've taken out corpectomy cages. And so we practice here on this campus, and, it's always a pain in the ass to get a vascular surgeon or a general surgeon to come over. And it was like trying to align, his schedule with my schedule. It never worked. It was always based on his availability, which was like, Monday morning at like 4 o'clock in the afternoon, or Monday morning when you already have a case scheduled. So these approaches have allowed orthopedic surgeons and neurosurgeons to do cases that you normally, would have to do with an access surgeon. So I've taken out a number of these cages just going in laterally. And a lot of the companies now have, really good retrieval devices. So they actually have an entire set devoted. They've got hooks in them. They've got graspers. They've got everything and anything you can think of. And again, on this lady, it was kind of a nightmare because she had 3 surgeries, had a CSF leak, had a lumbar drain in, and then the cage just kind of moved or had dislodged a little bit. And she actually had no symptoms, and none that I could tell other than the fact that this cage was slowly kind of moving around. And I told her, I said, look, we'll try to go in, and either I've drilled these out, and you can get in there and put your retractor down and use one of those long minimally invasive metrics kind of drills, and use a microscope. This one, we were able to, basically I put in like a cob and an osteotome above and below, and you can actually, I was able to put a little hook around it and just pull it out, like with one of those, slap hammers. You can just try to slap hammer out. And again, I've taken out a lot, and it's much easier to go in this way than to go back in and try to dig it out. I mean, and again, you can do it, but if you can try to. And then here's actually, this is the lumbar plexus. This is actually what it looks like. So today in the lab, we're going to go in and look. And if you're docked, you can see there's the L3, L4 transverse process. And those are the interconnections I was talking about. And I think a lot of times, those things don't necessarily show up on the neuromonitoring. And I've had patients, I think those interconnections are very important. And I think sometimes when you do that approach, you can bugger those interconnections, and that's what causes people to have the neuropraxias. But you can see here, there's no way you're going to be able to move these nerves. I mean, the lumbar plexus is fixed. So, and a lot of times we abandon, I'll abandon L4-5 or L3-4 if I don't feel comfortable doing it. And again, here's kind of, this is what we used to do in the old days, right? You just bovie everything out. And I was so paranoid I was more afraid of getting into the peritoneum when I first started doing these cases than the lumbar plexus, because in my training, I remember we used to, with my attendings, we would just, do these anterior approaches and just almost completely take out the lumbar plexus by going through the psoas and retracting it. But the important, for me, lateral surgery is all about the lumbar plexus. Doesn't matter, even if you're doing an OLIF approach, you really have to understand that anatomy. And again, what are the reasons for doing it? For me, it was not having a vascular surgeon, not having an access surgeon. It tends to be less blood loss because you're working in the disc space. Is it minimally invasive, minimally disruptive? I think it is. But, when you start doing 3, 4, 5 levels, you can do, I've done up to 7, 8 levels. it's a big hit for patients, even though it's minimally invasive. So we stage those, and again, I've learned a lot. I've had every single complication you can think of. And to me, the most dangerous level is always going to be L4-5. That level is just totally unforgiving. If you can understand and get really good at doing 4-5, then the other levels are much easier. And I think, again, I think the oblique approach is I'm a huge fan. If you can avoid getting in the plexus, I think it's a really slick approach and a good one to use. And again, what I've done here in my practice, we have a lot of patients who've had, trauma, thoracolumbar, thoracic, and, you can start to treat pathology like this, where you have a burst fracture, it's gone back pretty far posteriorly. And the way I would do this is a little different than a normal thoracolumbar approach. Is actually I would put the retractor like you're going to do an OLIF. You would stand in front of the patient on the belly side, and then I put the retractor and I go all the way back, and you can drill all that posterior bone off. But I use a microscope, just like you're going to do an open procedure. You do it the same way. You find the rib head, you get into the foramen, and you can drill the back wall off. Again, you could do this all from the back if you want. It just depends on your level of experience and comfort. And this is what we did for this patient. And revision surgery, someone who's got osteoporosis, a big patient, you can see just on the lateral x-ray, and again, most of these patients, it's poor body habitus, metabolism, they have osteoporosis. So, you can go in, but this patient ended up having, we had to go back in from the back. And I'll just show you, so I was able to get one of Dr. Chapman's, so that's Dr. Chapman's opening down there on the left side, and then that's the incision on my patient. So you can see the difference. You can still go in and take care of the problem, but it's just a little bit of a bigger incision. Do you remember that case, Jens?
Yep. Sure.
And again, you can see, you have the vascular surgeon, you've got all those different retractors, or you could just go in from the side and do a lateral procedure. And we've done a lot of, we've in the last couple of years, and this is another burst fracture that we did. You can see on this case, how difficult it is to see and I use the other levels to actually show where you're at, because a lot of times, like on this patient, I think they had a vertebral plana, so it's really hard to see the normal anatomy. So you can use anything, everything that you have to try to help you kind of navigate. And again, just like you're going to do an open procedure on these burst fractures, or if I'm doing a vertebrectomy, I always stand, I want to know, I'm looking at the cord, and I want to drill back towards the posterior wall. Whereas if I'm doing just a lateral interbody fusion, I'm standing posterior. And it's all about, like we talked about earlier, the most important thing when you're doing this is retractor placement. This is another case, again, for tumors. This is a good approach. I've even done, L4 corpectomies, and this patient who had colon cancer that Jens and I took care of, he's had multiple bouts of radiation, chemotherapy, and he had tons of tumor in. We went lateral, and then Jens went posteriorly and decompressed it. So it's a good, again, for somebody who's very sick, they're not going to live 2-3 years, but they want to get some, you want to get as much tumor as you can, give them good quality of life. The guy actually ended up living for about 3.5 years after our surgery. So it's less morbid, I think, than a huge, anterior, posterior. approach. And then this is another case that we did together where we went in. The patient had a burst fracture that was treated, and then I went in from the side and basically just drilled out the cage, and I couldn't get it out, so I used, all the companies now, Medtronic actually has a drill, but they all Stryker, everyone's got the metal cutting burr, and basically I just cut all the way across the cage because I couldn't get it to come out. And so finally, and that's what you see down at the bottom there, and you can see the drill that we used. And then I put in a lateral expandable, and then Dr. Chapman, I think, went in this. I actually think we did it the same day.
Yeah.
We went in and just basically, and you can see where the previous cage had kind of subsided because I think, again, it was, the older corpectomy cages, they're round and it goes right into the hypophyseal ring. So the newer cages that you have, the lateral ones, all of them are longer and they have much better, I think, end plate coverage. So I think, certainly you can still get subsidence, but biomechanically it seems to be not as much of an issue. And again, do we get bone graft that grows all the way across it? Honestly, most of my cases and the ones I followed, there's either fibrous tissue or it's the posterior stuff that's holding it. You just don't get the robust bone formation that you normally would using other devices or allograft, but it doesn't seem to be an issue.
It's stress shielded bone. So
Yeah.
You don't expect it to get firm and hard. It should be replaced.
Yeah, that's a good point. Yeah, that's a good point. Again,
Let me just add
yeah.
to that. This is a really important point because Amir was addressing that also earlier with the structured allografts. The best that we can actually hope is an on-growth through the first centimeter to 2 centimeters, almost an inch. It's the same for allografts. So it's probably actually a bad idea, and I've done that for so many years, to stuff, if you have a structural allograft, it full with autograft, because if it actually then revascularizes, it will remodel, meaning it'll eat up the allograft cortical shell and actually weaken it. So what we actually want in these large structural grafts, whether they're biomaterials like metal or a PEEK, or the allograft is an on-growth that goes into the structure itself and then rely on the structural integrity plus a posterior tension band to hold up definitively this device. So thank you for that very insightful comment.
And again, I don't know who uses BMP when they do these procedures. Go ahead and raise your hand. How many people use BMP?
Off-label.
Yeah, off-label. Okay, how about allograft? Who uses allograft? How about, does anybody use autograft? Wow, yeah. So, again, I don't know the right answer, but I think I agree with the comments in here about the bone formation, that you just don't get it. It's probably a good thing. Again, do you treat everything going laterally? Certainly you can. This is a patient of ours that, that fractured, and you can see she actually walked into my clinic with this, the only thing that she complained of is she had a hard time kind of standing up straight, and she has thyroid cancer. I've treated her for 8 years. It's absolutely incredible to me. And most of our oncology patients, they seem to be living longer and longer and longer and longer. And I was going to go lateral on her, but I stopped because guess what? She was extremely thin, and she was female, and she had osteoporosis. I was like, there's no way I'm going to go lateral on her. I'm going to get some catastrophic complication. So anytime... This is just my experience, is my worst complications have been in women who have osteoporosis that are extremely thin because they just have no retroperitoneal, there's no retroperitoneal space. Some of my worst complications, and I've had every single one, the anatomy is just so unforgiving. So I think, when I saw that, I'm like, you know what, I'm going to go in from the back. So that's what I ended up doing. And in fact, on her, I didn't even touch anything in the anterior. I just went in and basically went up and went below and was able to get pretty good correction. So that's it.
Thank you.
Yes.
I have a quick question. For L45, when you look at the MRI on the axial view at this level, they have the psoas, we have like the calcium.
Mm-hmm.
The lumbar plexus gets pulled more forward. So I've heard. Do you have any tips or tricks to deal with L45 via an XLIF approach when you have that phenomenon?
So I think so. When you go to the lab today, we have a great specimen I've dissected out for you guys. So the lumbar psoas is actually, and the plexus, it kind of fans out. So it's not really, a lot of times, people think, it's just this one and it goes in this one. It's really not like that. And you'll be able to see the femoral nerve and all the different branches. And so I think every patient is a little unique. And I think when I started doing this way before they had like neuromonitoring even, when I was doing it, there was just a retractor, and it was like a retractor company, and they had just started, putting their implants out. And so under the microscope, I was going through the fibers of the psoas. And so maybe it's that experience, but spending time in the lab like you do today, to actually see it and see what it looks like, it totally takes the fear away from working around it. But to your question is, I don't think there's anything you can do. And what I always do at 4 or 5 is go totally midline, like on the 50-yard line every time. And then if the nerve is close by, then I try to go a little bit anterior. But if you have to go any more posterior than that, then it's just, it's not worth it. Yeah, I just bail. Because, if you've had, and I've had quite a few femoral nerve injuries, it's such a pain in the ass. Your patients are just miserable. So
So I appreciate your honesty, and again, the clinical reality is these are breakthrough procedures, and especially with corpectomies, it's just incredible. Or degenerative scoliosis, I find it is so much nicer and meaningful for patients, either with an anterior-posterior or posterior-anterior connection. Now, here's my question. Understanding cross-sectional anatomy on preoperative MRI scan or CTA studies has become an art into itself. How much does this influence you in your XLIF versus OLIF considerations as you look at the height of the bifurcation and weird arteriovenous anomalies in these particular lower lumbar sections?
So that's a great question. For me, I think if you're doing a lot of OLIFs, the vascular, when you're looking at MRI, you can really see the veins. If you're doing lateral, it's not so much vascular, but it's still good. I always do anyways, just to see where everything is. What's more of an issue is if you, like in our practice, is dealing with these, degenerative scoliosis cases where I like to look at the coronal view on a CT scan because you can really see the vessels. I think it's something I'm more aware of now than I used to be. I used to not look at it at all. I would look at the osteophytes, but now I always look and I see where the iliac vein, iliac artery is. It's something I think, Jens, that we're paying more attention to it, but it's not something I routinely used to do.
For central stenosis and indirect decompression, how do you decide whether or not to put in your XLIF cage and perk them from behind and call it a day versus, or do you do your XLIF, wake them up and see how they do for the next day or so, make sure their leg symptoms are gone before you fixate them from behind to decide whether or not the indirect decompression for central stenosis is adequate enough?
So I think every case is different in terms of trying to decide. If I do more than 2 levels, then I'll go posterior. For central stenosis, typically, I don't think you can do a lot to, if they've got like bad facet joints and it's really tight, I don't think you're going to be able to solve the problem going lateral. I think you get, it's better for foraminal stenosis than central. I still think you have to go in and clean it out from the back. Again, I've sort of gone back and forth. Initially, I did do a bunch of standalones, and in the lumbar spine, I just didn't like it because there's too much movement. There's too much axial rotation. There's too much flexion, extension. There's too much forces. So if it's 2 or more levels, I think, I think you have to, I go from the back. And again, my experience is they get better initially, but if they have really a lot of central canal stenosis, usually you have to go in from the back. Ali.
This is the point, with like the whole concept of indirect decompression, you just do the discant, side, and it's great indirect decompression. If you don't do it most of them side, and you lose all of that decompression. In my practice, I started there with rod. I did a few of them where I would just put a cage in a unilateral screws, and even they would subside. So eventually, talking to a lot of people who would do just indirect decompression, most of them go to direct decompression, which is good with not getting a CSF leak or not scare you. But there's so much subsidence, even with the biggest possible cage, So I've changed my whole approach about that. I think just go in, put the screws in, get it decompressed, the redo rate, and it's really, really low.
Yeah, I agree, Ali. So we're going to move on for our last lecture, and then we're going to head to the lab. So Dr. Schuster is going to talk about doing O-lifts, and he's a colleague of ours. He's in Spokane, and he works at Northwest Orthopedics, and he's a great speaker and a great surgeon, and he's done quite a few O-lifts. In fact, I think him and Dr. Hines have probably done the most in the country.